Good morning, everyone. Today's lecture will be given by Marit Kalliswart, a fifth-year resident in our department. She's going to talk about postoperative red flags in upper GI and bariatric surgery. Enjoy.
Thank you. Yes, welcome everyone. So today we're going to talk about the postoperative red flags after upper GI and also bariatric surgery. So what are postoperative red flags? These are signs or symptoms after surgery that could indicate a specific pathology that can warn us for a potential serious or life-threatening complication. Important here is that we have like 3 pillars for the red flags. They can be subjective, what the patient tells you, objective, what you see, and also values in the lab value. So complications after upper GI and bariatric surgery. Here it's important that we do not only have the abdominal compartment, but also the thoracic compartment. And we also have the non-surgical complications or systemic complications. So first we'll discuss a case. We have a 20-year-old female with a body mass index of 37. She underwent a laparoscopic sleeve gastrectomy. It was an uncomplicated procedure. However, on the second postoperative day, she developed abdominal pain, vomiting, fever, and also tachycardia of 100 beats per minute. The inflammatory markers were also elevated with a CRP of 240 and a white blood cell count of 14. So question for the residents, what would you do?
Maybe CT scan?
Yes, that's correct. So we did a CT scan and we had a status after a sleeve gastrectomy. So what you can see here, the stomach is much smaller now because the sleeve was performed, and we have the staple line here that you can also see here, and right next to it there is additional air and also fluid, which is too much for the second postoperative day. So we had a suspicion of stapler line insufficiency. So the management was, of course, immediate antibiotics and also nil by mouth, and emergency surgery was performed. And in the diagnostic laparoscopy, an insufficiency at the stapler line at the angle of His, so very proximal, was seen, and this was oversued. Also an intraoperative endoscopic assessment was done, and the stapler line was now intact after the operation. With this case, we have the red flags that we saw are abdominal pain, fever, and also elevated inflammatory markers. But there's a fourth red flag. Does any resident have an idea?
Maybe that she developed tachycardia?
Yes, exactly. In bariatric patients, sometimes this is the only sign that there might be an anastomotic leakage or another problem is a tachycardia. These patients often do not present initially with abdominal pain. So what we'll further discuss today, first I will discuss the upper GI surgeries that we have on the esophagus, stomach, and also bariatric procedures. We'll go over the surgical complications, the non-surgical complications, and at last we'll discuss who is actually most at risk for these complications and preventive measures that can be done. The esophageal operations are mostly done for esophageal cancer, the esophagectomy that can be performed transhiatal, where there's only an incision through the abdomen, transthoracic, where there's also procedure through the thorax, and the 3 incision where they are mostly performed for the higher esophageal cancers, where there's also an incision in the neck. There are also operations for strictures. This can be the Heller myotomy, but this has been less performed because of upcoming endoscopic procedures. Then we have the stomach operations performed for gastric cancer. It can be an adenocarcinoma, gastrointestinal stroma tumors, or also neuroendocrine tumors. It can be wedge resection, partial, subtotal, or total gastrectomy, and often, especially in adenocarcinomas, a lymphadenectomy will also be performed, which is important because there we go very closely to the pancreatic tissue, and this can lead to a pancreatic fistula. Surgeries performed for reflux disease and hiatal hernia are the fundoplication, and we all know the Nissen or the Toupet, and hiatoplasty, and also the links or mesh implantation. Then we have the bariatric procedures. Here we have the gastric sleeve and the gastric bypass, and most centers will now have a standard of care that will be the gastric bypass. So the operative techniques that we have the classic open surgery, but in most cases this will now be replaced by a laparoscopic technique, and over the last years we have more and more robotic assisted surgeries as well. Then very important, especially in esophageal surgeries, that often also a thoracoscopy has been done, which can lead to other complications as well. So this is a study, a German nationwide analysis that has been done to assess the complications after upper GI surgery. As was billing data was used with data of more than 3 million patients. And as you can see here, we have the information on esophageal surgery and gastrointestinal surgery. And as you can see, a prolonged ventilation on ITU is more common in esophageal surgery. There are cases of peritonitis, so you see more often in gastrointestinal surgery. The anastomotic leakage was more observed in the esophageal cases, and also pneumonia was more common in esophageal operations. GI bleeding was, however, more common in the gastrointestinal operations, but overall, these patients are at a high risk for complication with more than 1/3 of the cases. An important topic here is the failure to rescue. So if a patient develops a complication, the risk of mortality is high. We know from esophageal procedures this can be is 20%, and in complex stomach cases, the risk for mortality when a complication has developed is around 28%. So this is why it is important that we all know how to respond to a red flag. So which are the complications that can develop, as we discussed before? Where we have the bleeding, we have the conduit ischemia, especially in esophageal surgery, that can lead to an anastomotic insufficiency. We have GI obstruction or paralytic ileus. Also an abscess can develop or a chi leak, especially when lymphadenectomy has been done. In the these complications can develop if a thoracic procedure was done, then we also have the pneumothorax. These complications can all develop in the abdomen as well, and here we also have additionally the pancreatic fistula. So what are the red flags? First, I would like to emphasize that it's important that you listen to the patients. When you go to a patient, do not just listen what the nurse tells you or only look to the vital parameters or the lab. Listen to the patient and stay calm and call help when necessary. And so first we'll discuss the surgical complications and the postoperative bleeding. And so we go over all the 3 pillars of the red flags. So subjectively, a patient can have pain, but already be like lethargic when the bleeding is severe. Objectively, you can see hypertension, tachycardia, also dyspnea if it's in the thorax. And important here is there signs of bleeding extraluminally or intraluminal? Extraluminal, you have to also assess the thoracic or abdominal drains, and intraluminally you might have melena or also hematemesis. In the lab, there might be a drop in globin. If you want to have a quick lab assessment, you can also do a blood gas analysis where you can see the drop in hemoglobin, but also assess the lactate and acidosis if it's there. So the timing mostly is the first 24 hours after surgery. Incidence is up to 8% in esophagectomy, 4% in gastric procedures, and in gastric bypass around 1 to 4%. Mortality, so the failure to rescue, is up to 25%. So the management of acute postoperative bleeding is divided. Is the patient stable or unstable? And if you see on the left side, if the patient is stable and you have signs that there's intra-abdominal bleed, so outside of the lumen, you can do a CT angio. If it's intraluminally, you can do an endoscopy. If the patient is unstable, it's important that the immediate resuscitation is performed with volume, transfusion of blood, and also an immediate evaluation of intensive care. If the patient remains unstable, surgery should be performed. If you can stabilize the patient, you can do further diagnostics. Then we go to the anastomotic leakage. Here the patient can present with pain or also dyspnea in case of mediastinitis. Objectively, you might see the systemic inflammatory response syndrome, or SIRS, with fever, tachycardia, and hypertension, signs of peritonitis, and also can assess the drain aspect. In the lab, you will see elevated inflammatory markers, and also here the blood gas analysis can help you further of how sick the patient is. Here it's also very important that what we assessed before, of what we saw before in the case, obese patients might initially only present with tachycardia. So timing, most of the times it develops around 5 to 10 days after surgery, but it can also be earlier, as what we saw in our case as well. The incidence is the highest in esophagectomies, up to 40%, gastrectomy around 2 to 6%, and gastric bypass 1 to 4%. Mortality can be up to 2 to 12%. Here it's important that the presentation will depend on the location of the anastomotic insufficiency And so here we see the esophageal procedures. If you have a high anastomosis, cervical anastomosis, sometimes at a presentation can already just be with that there might be some inflammation of the wound. If the anastomosis, if the leakage is intrathoracically, patient can present with signs of mediastinitis. This is in the case of a gastrectomy. As you can see here, there are three sites of a potential leakage. First is the esophageal jejunostomy. When it's higher, patient can also develop with thoracic symptoms. If a Roux-en-Y reconstruction is performed, there is a duodenal stump that can also cause leakage, and less frequently, but also that could cause problems, is the jejunostomy. Then in case of bariatric surgery, we have the gastric sleeve, and what we saw in our case is that this patient had insufficiency at the angle of his, so very proximal. This can also be the case in a gastric bypass, but here the gastrojejunostomy can develop a leakage as well. Here also less common is a leakage at the site of the jejunostomy. So the management of anastomotic leakage. Also here, if the patient can develop a septic shock, so resuscitation if necessary, start broad spectrum antibiotic therapy, nil by mouth, and also CT scan should be performed. Here it's also important that you do oral and IV contrast. There's also a place for endoscopy, which we discuss here. So where we have CT and endoscopy, first that a CT is non-invasive and you often have it quickly available. And you have also a visualization of the periluminal tissue, as you can see here on the left side, that there is a passage of contrast into the pleural space. However, for endoscopy, here diagnosis and treatment can be done in one, which I'll discuss afterwards. However, you have no visualization of the periluminal tissue. You need sedation, and also depends on the work of the endoscopist. But most often they are complementary and used simultaneously. So further therapy of the leak, surgical treatment is indicated for larger leaks, but there has been an upcoming place for endoscopic treatments as well. Stents can be used, but over the last years, where our center also has a lot of experience, is the endovac therapy. And as you can see here, there are two options. Here, if there's a small leakage sponge that is connected to a suction system, like we also use it for our wound problems, can be used, and the sponge can stay in there for 4 to 5 days, and then an evaluation can be performed. If there's a larger leak or perforation in case of Boerhaave syndrome, it's also possible that the sponge is placed outside. Our center has a lot of experience with the endovac therapy, and we have also now are doing preventive management with a preemptive endoluminal vacuum therapy in case of an Ivor Lewis esophagectomy. And this was a retrospective case series with 67 patients where a sponge was placed by the gastroenterologist intraoperatively, and the sponge was left in situ for 4 to 6 days, and then an evaluation was done, and a sponge therapy was continued if there was not complete anastomotic healing. So what I've discussed before is that there's an incidence rate of anastomotic leakages in up to 40% of the patients in case of an esophagectomy. In this series, only 8% of the patients had an anastomotic leakage, and only one patient with an uncontained leak. 90% of the patients had a prolonged sponge therapy, and 73 patients had an uneventful anastomotic healing. So that were the surgical complications, but we also often see non-surgical problems after upper GI and bariatric surgery. I would like to ask the residents if they can tell me which complications you see here.
Arterial fibrillation and pneumonia?
Yes, that's correct. So we have atrial fibrillation on the left side, and also signs of pneumonia with an infiltration in the right lower lobe. So non-surgical complications are most often pulmonary or cardiac. We have the pneumonia in rare cases. Also an ARDS can develop, pulmonary embolism, and of course the exacerbation of a COPD in case patients that we have quite patients with cancer are often smokers as well. Cardiac complications are most often the atrial fibrillations or myocardial infarction. So pneumonia. Often the patient presents with dyspnea, tachypnea. It can also be lethargic. Objectively, you can have again the SIRS with fever, tachycardia, and hypotension, and also hypoxemia. In the blood, you see elevated inflammatory markers, and also an arterial blood gas should be done. So here the timing is usually within the first 5 postoperative days. The incidence is up to 20%, especially in esophagectomies. Diagnostics, of course, chest X-ray, CT thorax, and also sputum culture should be done. Then the treatment, antibiotics and supportive cares, very important here with early mobilization, analgesia, and also physiotherapy. Here it's also important to rule out other causes of dyspnea, pulmonary embolism. Then the atrial fibrillation, which has kind of a special place in upper GI surgery. Patients often present with palpitations, angina, or dizziness. You will see an irregular pulse, often tachycardic and also hypertension. In the lab, you have to watch the electrolytes, inflammatory markers. You can also do a blood gas analysis. Here, the timing is also usually within the first 3 to 5 postoperative days. Especially in esophagectomy, again, we have the highest incidence rate, up to 20%, and diagnosis are in ECG and cardiac markers. Important here is that atrial fibrillation can cause acute shock as well. When a patient has a very tachycardic atrial fibrillation, the cardiac output can be limited and causing acute cardiogenic shock. What is also important is that atrial fibrillation can be a warning sign itself. In this study, published in 2019 in the Journal of Thoracic Diseases, following an esophagectomy in atrial fibrillation, in 3/4 of the cases, it was associated with an inflammatory complication like an anastomotic leakage or pneumonia. If there was no inflammatory or an infectious complication, often a pulmonary overload was seen. So here, treatment is resuscitation if necessary. A cardiac evaluation should be formed where they can choose between the rate control and rhythm control, and also anticoagulation should be started. And of course, very important, detection of the underlying disease. So that was about the most common complications we have, but who is actually at risk for complication? Here it's important to have a patient characteristic, age, but also history, had a diabetes mellitus, metabolic syndrome, and also cardiac and pulmonary history, especially with smoking. Often a patient with cancer will have had a neoadjuvant therapy, chemotherapy or radiotherapy, and also nutritional status is very important. We have like the 2 extremes. If the BMI is very low, and the patients with cancer, you will see a cachexia, malnutrition. But in cases of a very high BMI in patients, in bariatric patients, they're also more at risk for postoperative problems. Of course, surgical technique is very important. For most elective operations, the minimally invasive techniques have already replaced the open techniques, which we know that patients have less pain, mobilize earlier, and also have less wound problems. Then preventive measures that can be done preoperatively, especially in the cancer patients. Physical therapy, the stop of smoking is important. Nutrition, especially in patients with dysphagia that they cannot eat, enteral feeding should be considered. In bariatric patients, often preoperative, they already have a nutritional consultations and they will be asked to try to lose some weight before the operation. Postoperatively, again, feeding is important, preferably enteral, but if not possible, parenteral, and also physical therapy, analgesia, and mobilization. And of course, in the case of esophagectomy, we have now the endoluminal vac therapy. So, take-home messages. We have the 3 pillars of red flags. It can be subjective, listen to what the patient tells you, what do you see, and also laboratory values. It's all about changes. Red flags can develop rapidly after upper GI surgery. A frequent patient evaluation is essential, and inadequate management can have devastating consequences in contact with the failure to rescue. Thank you for your attention.
Okay, thank you very much. Important topic for every field of surgery, and this concept of failure to rescue, which now is established everywhere and probably one of the most significant marker of quality and good outcome. So maybe my question to Professor Guccio, when I see this, it's important to know you described that well. Now that has also to do with the process in the hospital. And since you were trained in Germany and with us, what's the role of expert team or specialization in recognizing this early problem, reacting and preventing deaths? You have two systems, the one we have here where we are specialized like many centers with a group focused on upper GI surgery versus a system which is disappearing worldwide but not everywhere, when you have surgeons doing as well rectum and pancreas and upper GI, all those centralized, although in big centers. What's the data or what's the your opinion about these two ways of handling patients?
Thank you for this nice presentation and the question. I think this is all about centralization and of major visceral surgery, basically. I think centralization can only be performed adequately with dedicated teams that really focus on a specific disease and also have a specific interest in outcome research to provide adequate quality. I think this is the major difference between those two systems. I think there's also over-centralization. It has also been shown that too many cases of one specific pathology performed in by a certain group, there's also a plateau of a maximum number of cases per surgeon or per center. After reaching this plateau, quality does not grow anymore and even may drop. So if you perform, I don't know, 500 pancreatic surgeries per year, you might not be as dedicated as before towards a single patient. I think there's maybe an ideal number of patients that you can look after adequately and manage. But I think the big difference is the dedicated team that looks after the patients from the beginning, starting with indication, over operation, management of the complications, and also adequate monitoring of complications, and this also involves auditing by external registries and etc. This is the way we have to go to reach optimal quality in patient care. This is my opinion. Thank you.
So the talk was so clear that one of the mechanisms is that we have no further questions, and so thank you very much. Thank you.